So thank you all very much for having me. Thanks the organizers for inviting us. And today I'm happy to share a little bit about our work on mechanisms of surgical stress resistance by dietary restriction. So just as a brief outline, I'm going to talk a little bit about actually starting with aging, because we're from the Laboratory of Healthy Aging at ETH Zurich, and how dietary restriction interfaces with aging, and then moving on to dietary restriction and surgery, and a short story in one of our preclinical models with some unpublished data. And then finally, I'll wrap up talking about future directions in terms of translating these findings into the clinic. So the global population is rapidly aging. There's already over 1 billion people over 60 years old, and this is expected to double in the next couple of decades. So while it's great that we're all living longer, the flip side of this is that it presents some significant public health challenges. With a larger aging population, we have a larger group of individuals who are experiencing chronic disease. So we can see here that from the age of 40 onward, the risk of most chronic diseases increases exponentially. And with age and these diseases that often require surgery, we also see the resilience against surgery decrease. So here we're seeing 90-day survival times after major abdominal surgeries. And we can see that as age increases, the probability of survival decreases after surgery. So we have this dual problem. We have a rapidly aging population who's more likely to need surgery due to chronic disease, but is also simultaneously more susceptible to surgical stress. So how do we go about conceptualizing and solving this problem? Well, we think about it in terms of this framework called the geroscience hypothesis. And in this framework, aging really sits at the root of all of these diseases and is the causal driver of all of these pathologies and diseases, including surgical stress susceptibility. So within this framework, we hypothesize that an intervention which directly addresses the root cause and treats aging will simultaneously reduce the risk of these chronic diseases and improve these associated pathologies. So we are approaching the problem of surgical stress susceptibility through the lens of this geroscience hypothesis. And so what are interventions which directly treat aging? Well, for over 100 years, we've known that dietary restriction, specifically calorie restriction, extends lifespan and extends health span. And this is really a seminal demonstration of this by the group of Clive McKay at Cornell in 1934, where they first showed that when you restrict calorie intake in rats, you can extend the lifespan, and not only extend the lifespan, but extend the health span, which is the period of life spent without major disease. And so here they're showing on the right the rat which has undergone lifelong calorie restriction compared to the rat on the left which hasn't. And since this discovery in the early 1900s, this finding has been replicated across numerous species, from yeast and Drosophila all the way up to non-human primates. So this response to restriction in dietary energy is clearly a fundamental and evolutionarily conserved response. Since this time, it's also been discovered that not just restriction of calories isn't the only effective form of dietary restriction. So in addition to restricting energy intake, a popular theme recently has been restricting feeding period. This is called time-restricted feeding. And in this paradigm, the eating window is restricted to a few hours a day, which implements an extended daily fasting period. And so Sarah, when she was working with Rafa DiCabo, did a really key demonstration of the effects of time-restricted feeding, where she showed that compared to the ad libitum, or freely fed mice in the black line, restricting calories by 40% substantially extends lifespan. But if you feed the mice the same amount of calories, but just restrict their feeding period to a few hours a day, thus imposing a fasting period every day, you also can get a significant extension of lifespan. So this shows that daily fasting is not as effective as calorie restriction, but a good alternative. And then finally, there's nutrient dilution, which is what our group has been most interested in recently. And in this approach, a single dietary component is restricted without restricting total energy. So when we think of this conceptually, a diet is made up of energy from 3 macronutrients: carbohydrate, fat, and protein. So it's been shown multiple times that by restricting protein from about an average of 15% of energy to 5%, we can recapitulate many of the effects of fasting and calorie restriction. But it's also been shown that we can go even further into the protein component. So the protein component is made up of non-essential and essential amino acids. And by restricting just 2 of these amino acids, the sulfur-containing amino acids methionine and cysteine, we're able to extend longevity and extend health span, this is in rats, to an almost equivalent extent as calorie restriction. So over the course of the past 100 years of research in this area, we've seen that there are multiple dietary restriction interventions, fasting, calorie restriction, and amino acid restriction that can all show significant geroprotective effects. Now, looping back into our hypothesis that these geroprotective interventions should show protection against surgical stress. So what's the evidence here? Well, the first demonstration of this was done by our mentor, Jay Mitchell, in his postdoc work in Rotterdam. And what Jay did here was take mice and subject them to between 1 and 28 days of dietary preconditioning. The mice then underwent a kidney ischemia reperfusion injury. So in this surgical model, the blood flow to the kidney is cut off for a specific period of time, and then it's released to allow blood to flow back in. And upon this reperfusion, tremendous damage to the organ occurs. And this is really a clinically relevant model because many human surgeries require periods of ischemia to critical organs like the heart or the kidney. Animals were then refed ad libitum, and in this case, survival was monitored. And so what Jay saw was that compared to the ad libitum fed animals in black, who only about 10% survived beyond a week, animals that were fasted for just 1 day showed 90% survival. So it's a tremendous protection from just 1 day of fasting. Animals that were fasted for 2 or 3 days, or animals which underwent 30% calorie restriction for 14 or 28 days, displayed complete protection, 100% survival from the ischemic injury. So this was really a foundational proof of principle of this idea that a geroprotective dietary intervention can protect against surgical stress. And in the time since then, Jay, and as we worked with him and before, he showed that a number of different dietary models protect against a number of different surgical stresses. So, for example, Jay and Chris Hine showed that both restricting protein and methionine and cysteine protect against liver ischemia reperfusion injury. And here's a representative image of a liver after the injury. So you can see here these dark red areas are basically dead cells undergoing necrosis. And whereas we can see when protein is restricted, these areas of dead cells are much more limited in area. It's a really strong protection. They also showed that restricting individual amino acids, leucine or tryptophan, can protect against ischemic injury. And then most recently, we showed with Alban Longchamp that restricting methionine and cysteine can promote the growth of new blood vessels in a hind limb after it's been, the blood supply has been cut off. Though we can see that across a wide range of surgical injuries, different modes of dietary restriction are all showing significant protection. So most recently, we've been interested to really dig into the molecular mechanisms that underlie these protective effects, because we were kind of hypothesizing that if we see protection from fasting and calorie restriction and amino acid restriction, there may be common underlying mechanisms that explain the protection across these diets. And so I'm going to tell you a short story about an unpublished story that we've done in collaboration with some of our surgeon collaborators in Leiden. So in this model, we're using a vein graft disease model in mice. So vein graft disease is really important for humans because there are a number of surgeries which require grafting, and that includes coronary artery bypass, which is classic open heart surgery, as well as carotid or femoral bypass surgeries, and also AV fistula placement for dialysis access and renal failure. And so what we do in this model is we take the mouse, we harvest a vena cava from a donor mice, which is a vein, and then we put the vein there in panel C into the carotid artery, so into arterial circulation. And this is what happens in the humans. The vein has to be placed into the arterial circulation. And so what we see, this is an example of a graft in the mouse, and so on a high-fat diet, the issue with vein grafts is that over time, this luminal area where the blood is flowing occludes. And it's because of a process called intimal hyperplasia, where this intimal layer grows and grows and continually restricts the blood flow. So what we're trying to do is reduce intimal hyperplasia and maintain a larger luminal area for blood flow over a longer period of time. And so what we can see here is that 3 days of fasting prior to the operation, here on the right, causes a significantly larger maintained area for blood flow. So we can see that, that fasting can protect against vein graft disease in this model. We've also seen that protein restriction in this more recent publication can also significantly protect against vein graft disease. So in a similar effect, we're seeing multiple diets producing similar protection. Now, what we've been working on most recently addresses kind of a finer detail of the surgical procedure. Though in humans, there's some debate about what's called the touch versus no-touch method. So the vein is encased in a layer of fat, this so-called perivascular adipose tissue. And in some cases, a surgeon will remove the fat off of the vein before the graft, and in other cases, the surgeon will leave the fat. And there's some question about whether one method is better than the other. And so what some really excellent microsurgeons that we collaborate with found when we were working together in Boston was when they test the effect of taking away the fat versus leaving it, there's really not much of an effect. But when we implemented a dietary restriction, which is a week of methionine and cysteine restriction, we saw substantial protection when the fat was removed. But when we left the fat on, there we saw the most robust protection. So we found that we had this really interesting finding that the diet seems to be interacting with the adipose tissue on the vein to promote protection. So to try and figure out the mechanisms of how this was occurring, how this diet tissue synergy was happening, we turned to a new method which we're quite excited about in our group, single-cell RNA sequencing. So with this technique, we were able to take the adipose tissue, isolate all of the cells in the tissue, and measure gene expression in each individual cell. Over here is about 80,000 cells from 8 different animals. So we're able to get an incredibly detailed view of how gene expression is changing in this tissue in response to diet and in response to surgery. And so what we can see is that in the depot, we cluster the cells according to their gene expression profile, and we can classify the cells based on their expression. So for example, here we see cells which are characteristically adipocytes. We also see a number of immune cells like monocytes and B cells, as well as macrophages. We see endothelial cells. So we can really get an incredibly detailed picture of what's going on in the tissue. And here where each dot is a cell, we can color the plot differently. So now rather than coloring it by cell type, we're coloring it by diet and surgery group. So where the orange and green cells come from mice which were pre-op on either control or methionine restriction, and the cells in red and blue come from post-op animals fed either control or Med-R. So we can see that in terms of global gene expression, there's a massive shift that's induced by the surgical intervention. But we can also see that there's pretty substantial shifts caused by the diet. So for example, looking at these clusters, these are all adipocytes, but one cluster is from the Med-R group and one is from the control group. And so what we can do is dig into these differences even in finer detail now. We can analyze just these clusters alone to say, how does the diet affect this specific cell type in this tissue? And so when we do that and analyze only these adipocytes from the pre-op condition, here we're looking at the expression of hundreds of individual genes within this cluster, and we can see what genes are expressed in the control versus the Met-R condition. And so genes which deviate from this regression line would be the most differentially expressed. And what we interestingly saw was that the most significantly upregulated gene in the adipocytes by the diet is PPAR alpha. And this is a really interesting target because it's a mediator of fatty acid metabolism. It shifts cells to a fat-burning phenotype, and it's really a key player in a lot of the fasting responses. And so when we look at expression of PPAR alpha in individual cells in the MET-R versus control groups, we can see a robust increase in expression, and then we can also see significant increases in the downstream targets, lipin-1 and SLC27A1, for example, which is a fatty acid transporter. And when we look at pathway analysis, so basically looking at what these differentially expressed genes represent in terms of biological processes, we see a really robust enrichment of fatty acid metabolic pathways. For example, regulation of lipid metabolic processes, organoacid metabolic processes. So this really tells us that the diet is shifting these adipocytes to a fat-burning mode in probably a PPAR alpha dependent manner. And why we think this is interesting is because the fat in the arterial circulation has this phenotype. So what we think is happening is we're adapting the venous fat to a more arterial phenotype before we graft it. One other interesting cluster that we looked at was the post-op macrophages, because these are the main resident immune cells after the operation. And so we can compare the control versus MET-R macrophages in this cluster. And when we performed pathway analysis, we saw something relatively surprising. The main enrichments were based on fibrosis and extracellular matrix deposition. And when we looked at individual genes here, we saw that fibrotic collagens like collagen 5A2 and 3A1 were significantly higher expressed in the control group, and that the diet tended to downregulate the expression of these fibrotic collagens. So what we think may be happening here is that the diet reduces the rate of fibrotic deposition around the graft, and this allows for better outward remodeling. So we're really excited about these techniques. We think that these high-dimensional single-cell techniques give us an unprecedented view of what's happening in the tissue, and we're working on a number of different projects in this area. For example, here we've generated a single-cell data set of the aging kidney with and without surgery with our ischemia reperfusion model. And then finally, just to wrap up, I want to talk a little bit about how we're working with some surgical groups to push these findings into the clinic. So as we heard earlier, there's a number of questions out there as to how to best implement these in humans, implement these findings on dietary restriction. So there's a number of methods we can look at: fasting, time-restricted feeding, calorie restriction, amino acid restriction. So how do we determine what the optimal method is? And there's some key factors we have to consider. The most important is, of course, safety. The intervention has to be safe for the population it's going into. Efficacy is also important. It needs to work. And then equally important is compliance. So we need the people to comply with the diet and do the intervention. And this is highly related to the burden. So if we're putting very high burden interventions, we're going to see lower compliance. And then the last factor that I think we need to think about a lot is surgeon acceptance. So many medical practitioners have very strong opinions on nutrition and how patients should be fed around surgery, which may or may not align with the data we're seeing. So we need to really be careful about explaining these data to surgeons and making sure they're willing to put them into patients. And so we've been fortunate to work with a great group at Brigham and Women's Hospital in Boston, led by Keith Ozaki, to test an intervention in elective vascular surgery patients. Here are just two papers which are published so you can see the details. But just at a very high level, what was done was 4 days prior to a bypass surgery, patients underwent 30% calorie restriction on a low-protein diet, so 4% of energy from protein. And this was carried out by putting the patients on an exclusively Scandi shake diet. So this is a semi-purified mixture that so they were on a liquid-only diet for 4 days. And so what I can tell you is that this intervention was safe. We weren't powered for efficacy, and it was feasible. But what I also will say is the patients didn't particularly like this product, and it was relatively high burden on them. So it may not be the optimal method moving forward. And then what's going on right now in collaboration with Alban Longchamp in Lausanne is a time-restricted feeding trial. So they've designed a trial also in bypass surgery to do an 8-hour time-restricted feeding for 2 weeks prior to the surgical intervention, and they're doing no additional dietary advice. So the patients take the usual diet, but in an 8-hour window. And this trial is underway. They've enrolled about a dozen patients already. And here's just some example data. They're tracking the patient intake using a cell phone app, which seems to have quite high acceptance from the patients. And here we can see eating events in green across time of day and different days in control versus TRF patients. So there are some really encouraging signals that there is compliance in a good amount of the patients. So in summary, we've shown that fasting and dietary restriction are geroprotective, that these geroprotective interventions protect against surgical stress. We told a short story about how methionine restriction can precondition and protect against vein graft disease. We're really excited about these single-cell techniques and how they can help us achieve a really deep understanding of mechanisms of protection. And finally, we really need to keep working on clinical studies to identify the optimal methods to implement dietary restriction in the clinic. So I'd like to thank a few people specifically. First, I'd like to thank Sarah, who's really the leader of our group now at the ETH and been really key in all of these studies. I'd like to thank Dr. Peter Kipp, who's a surgeon at Leiden University Medical Center and was key in a lot of the vein graft models, as well as Keith Ozaki at Harvard Medical School, who had really spearheaded the protein calorie restriction clinical trials, and then Alban Longchamp, who's working on the time-restricted feeding trials. And then really just to recognize and remember our mentor, Jay Mitchell, who was really, these were his ideas, and he really drove this field forward, so we're really honored to be able to carry on the research and carry on his legacy in this field. And with that, thank you for your time.